We have Dr. George Puthuran from Arvind Eye Care System, Madurai. He is the director of Arvind Eye Care System at Madurai, the glaucoma department. He's going to talk to us on how to do a perfect tube.
Thank
Over
you.
to you, George.
Yeah,
So would George modify some of his?
I don't think I should even try because Dr. Leon has multiple times he has said both the Ahmed and the Baweld are horrible. Anyway, I have been given this topic, so I'll just, I have no financial interest to disclose. So I have 7 pearls for 7 minutes. Pearl 1 is, as Dr. Manish and Professor Kirti said, conjunctiva and tenons is so very critical. If you don't have adequate conjunctiva and tenons, don't attempt the tube or the valve. Restrict the incision to the selected quadrant. This is extremely important. If it's a supratemporal quadrant, stick to the supratemporal quadrant, have relaxing incisions, vertical relaxing incisions. Why it is important is, as glaucoma surgeons, we are not used to identifying muscles, and once you are in the correct quadrant, and you can easily hook these adjacent rectus muscles. Pearl 3 is gentle priming, which is becoming more and more important in valve implants. Pearl 4, intraluminal stenting with 3-0 multifilament nylon. I have a video of all this, and watertight occlusion of the tube in non-valve implant with 6-0 polyglactin suture. This is very important. You need to position the anterior edge of the episcleral plate, whether it's an Ahmed or a Baweld, or an RD, at least 9 to 10 millimeters posterior to the limbus, and position lateral wings of the non-valve implant beneath adjacent rectus muscles. So this is the supratemporal quadrant, vertical relaxing incisions, and if you go in, you will come out with the superior rectus and the lateral rectus in that particular quadrant. You need to go into the middle of the supratemporal quadrant, so you can nicely identify the muscle. It's extremely important to take out the tenons along with the conjunctiva. If there's any kind of adhesion between the tenons to the sclera, it's impossible that the episcleral plate is going to go sufficiently posteriorly. You need a second muscle hook to create space beneath the muscle. Make sure that there's no adhesions on either side. So that is the lateral rectus. And even for an Ahmed glaucoma valve, it will be good to have it right in between the 2 muscles. And this is the, every non-valve implant in our hands nowadays gets the 3-0 multi-filament nylon, Supralon, which is available from Orolab. And the first watertight occlusion suture with the 6-0 polyglactin is over the Supralon suture. So at this stage, you need to check for complete occlusion. You can use a 27 gauge cannula to inject balanced salt solution. And if you have a small bubble inside the tube, you can easily follow that bubble to see whether it's going beyond the suture. Or see that jet of fluid that comes out is also a clear indication that it is completely. So that was the first knot, 2 throws, then the third, then the 1. So it's actually 2, 1, 1, 1 over the supralon suture. And these knots should come to the side of the tube so that there's very minimal risk of exposure. So the first wing of the RD goes beneath the superior rectus. It goes in, this is contoured to the shape of the globe. It is flexible, and it's designed to position beneath adjacent rectus muscles. So once the tube bends, that is a sign that the muscle, it has hit the muscle belly. Now the lateral rectus, you can switch hands. You can give the tenons to your assistant. See, the assistant is holding the tenons there, and you can switch hands, slide the lateral wing underneath the lateral rectus muscle. If there's any kind of adhesions there, this doesn't, and this movement is critical. This is a clear indication that it is positioned beneath adjacent rectus muscles. It can move sideways, it can move back, but it cannot move forwards because it is beneath rectus muscles. Another thing for young surgeons, we are dealing with very thin scleras. So while you're fixing the positioning holes with nylon sutures, you should make sure that you're seeing the needle and the suture through the sclera while you're passing those. Even for the box suture, which you will be using to stabilize the tube, you need to see the suture, to see the needle through the sclera. The second 6-0 polyglactin, the 6-0 Weichel goes beyond the supramid. See, this is what I was telling you about. See where this plate is positioned. This is right at the center, must be over the rectus muscles, and see this distance from the limbus to the anterior edge of the episcleral plate, and things can go horribly wrong. The pearl number 7 and the final pearl is to bury the tube in patient's own sclera in a 23 gauge needle generated scleral track of adequate length and depth. And also to ensure an optimal 2 millimeter length of the tube as far away from the endothelium as possible. So this is the groove we make. This is 2 millimeters. For a right eye or a left eye, it is 2 millimeter medial to the original position of the tube. And then this is your 23 gauge needle generated scleral track for tube insertion into the anterior chamber. Again, some accurate measurements are made intraoperatively to make sure that an adequate length, an optimal 2 millimeter length of tube is there in the AC. We try to drape the tube straight, in the straight position, measure 2 millimeters, involve that mark in making the anterior bevel, and then if you route it medially, ultimately you get an optimal 2 millimeter length of tube in the AC. You also have adequate length of tube available later on for, just in case you need to do another surgical intervention. So you can see this was the original position of the tube, and the supralon suture is buried into a pocket in the subtenon space. So this is how it looks. Why this 4 millimeter scleral track? All tube exposures are usually within 4 millimeter length from 4 millimeter from the limbus. Beyond that, tube exposures are much less. So if you can bury the tube in a 4 millimeter track, which is of adequate length and depth, at majority of occasions, tube exposures are taken out of the equation. So whether it is the right eye or the left eye, our tubes are always medial. And it also is a position where it has minimal contact with the upper eyelid. Again, tube position is critical. You need to make a slit and see the slit between the cornea and the tube should be as far away as possible, and the tube should be as close to the iris as possible. Tubes cannot be left close to the endothelium, and you find ways to make this work. In our hands, this anywhere between this 2.8 to 3 millimeter, that is where we try to dip into the anterior chamber. Till then, it is parallel to the sclera. Once you reach the 2.8, 3 millimeter, depending on the chamber depth, you dip into the anterior chamber, you get an adequate position of the tube in the AC. Thank you very much.
Thank you, George. That was so beautifully